I'm not a pulmonologist. I'm a gastroenterologist. Over at the VA, I run the GI division over there. Thank you very much for the invitation. They asked me to make sure to give it an introduction to making the diagnosis, the process of diagnosis. And I see a few fellows, that's great. If you haven't sat for your boards yet, for your internal medicine boards, that's your chance to practice some of this today. We're gonna do a little hands-on, a little bit interactive. This is working well for my GI fellows, so I'm hoping it works well for you guys. All right. So since we have a program, I'm just going to get started here. Quick disclosures. I have no financial disclosures. I do not speak for pharmaceutical companies. I'm a methodologist for the AASM, and therefore I cannot be having any industry relationships. Co-founder of the US Great Network, co-founder of the Evidence Foundation, past chair of the American Gastroenterology Association Guidelines Committee. So what are we going to talk today about? One thing that is sometimes a little bit mysterious because we go through medical school, we go through residency, and there's certain things we learn in terms of diagnosis. And sometimes it's good to revisit this and to see, is this sort of the way we look at diagnostic studies, that we look at the evidence for making a diagnosis, whether it's still sort of what we learned before. So that's always a good thing. Now, obviously, I can't cover everything today, so this is just going to be an introduction, and usually there's more to explore, obviously, particularly when you want to write guidelines, for example, for diagnosis, then it becomes a little bit more involved. So, but we're not going to talk about that today. So there's obviously good and bad tests, and we need to talk about those. And we need to talk a little bit how you would start critically appraising diagnostic accuracy study. We can't really spend a lot of time on this yet, because we still need to get this introduction out of the way. So how do we make a diagnosis in clinical medicine, right? Sure, you could apply intuition, see a lot of patients repeatedly, and then over time, so the convention of wisdom is that we will then get better at it and eventually then have sort of the experience to diagnose people. Okay, very good. Can everybody see that? Okay, we can make that small. Perfect. All right. So I hope everybody can see that. Everything. Can you hear them when they have order? Can they see the comments? So please go into the comments if you can't see things or you can't hear me. Let folks know about this. Okay. So that's good. Pattern recognition and then getting a likelihood for diagnosis. Now, that is obviously a time-honored system, but in the end, what we need to think about is a little bit more into depth and more quantitatively, hopefully at some point, think about what is our pretest probability versus our post-test probability. That's usually how we approach things nowadays. Because ideally, obviously, we would like to give recommendation in terms of using tests that are really based on evidence instead of gut feeling. And one thing that I see getting sort of mixed up a little bit, particularly about our fellows, is essentially to not think about that there is, whenever you see a patient, it's a spectrum of your pretest probabilities, right? Whatever you do, take a history, physical examination, run a test, right? There's always this probability that the patient may have that disease or may be positive for that test, right? And usually what we think about is that there is, the thresholds are to say, well, if we really know that it's 100% positive, why are we running a test? So once it crosses that thresholds, we should probably not do any tests. So if it's really completely unlikely, we should not run tests. And if it's really, really likely, then we should be running tests, right? Not running tests either. So there's this middle ground where we really should be running the tests and think about whether the test helps us in making a diagnosis and really, in the end, which we have to get to, help the patient, right? So you've all seen this probably when you're in the ICU or something like that, right? Who wants to get an ultrasound? How do you make the diagnosis here? Right. That's the ultimate, but you know, I think you guys all know you just put the hands on. You can close your eyes, put your hand on the belly, and your ultrasound is your hand, and you're done. Because it feels very, very typical, right? Sometimes I see them, you know, residents wheeling the ultrasound. And I say to them, I think you're across that threshold. We don't need this. This is not a tumor, right? This is perfectly round. This gotta be fluid, right? And there's obviously a dead giveaway over here. Let's try to. Okay, so these are the extremes. Please don't run any tests with that. Okay. Oops, wrong way here. So essentially, alternatively, let's figure out how we can use those tests. Okay. And then the question comes up when we have additional tests, is this a good test, right? So good tests versus bad tests. Usually what we want to do is to sort of think quantitatively a little bit about this, right? A very simplistic kind of 2x2 table. Let's take a patient comes into your office, and I promise you there's a lot of going to be GI exams. We have lots of different examples. But this is an interesting question because it is a history, and many people don't think about that history is a test. This is a history question, increase in abdominal girth. How do we approach it? This is a test, right? So we can put this in and fill in the little things in the middle here, which we will do in a second altogether. And then do some sums in here, and what's the sensitivity for this particular test? And so sorry, I will be picking on the first just so that we can get the hang of this. I know this will be in your boards, and so see this as a little practice session, just because they will throw at you some questions, and within 90 seconds you will have to have the answer. And I will promise you, by the end of this session, you'll be able to do this in your sleep. Any thoughts?
110 or 87 over 100, right?
Okay, so in percentages, that would be
87.
87. Okay, perfect, very nicely done, perfect. So as you know, then clearly that when you have that in your mind, this kind of 2x2 table, and just think of it always the same way. Always put the test left, always put the disease on top. Think vertical for your sensitivity, specificity, right? And do we have some more that we need to worry about? Okay, very good. Positive predictive value, horizontal, right? So that's great, and that's usually how we think about this from the start. There are other things that we talk about, obviously. So horizontally, vertically, sometimes you'll see this weird thing. I recommend not to use it. So it's essentially putting those two things together and coming up with 1% for the accuracy of a test, not helpful for clinical medicine. All right. The problem is that a director of a hospital, what is the director of the hospital really interested in when they buy a new test down in, you know, in the lab? What are they interested in? Over. So they're usually interested in sensitivity and specificity. A new ELISA comes in, you know, Hep C when I was a fellow, we went from the second to the third generation, and wonderfully it had more sensitivity and more specificity, and then the director can swap it out and put the new test on the shelf. We're all happy, great. What are clinicians interested in? Outcomes, very good. That's ultimately what we're interested in. But in the context of diagnosis, We're interested in positive and negative predictive value. The problem here is that sensitivity and specificity are independent of the prevalence, and actually positive predictive values and negative predictive values are actually dependent on that. So this is some of the confusion that can occur. So therefore, we'll do some work. I apologize that we don't have work today. We came early in the morning, and no, I'm going to give you some to work. So I will give you, we have 4 challenges, and I'll just pick randomly. Can I pick on you to do the first one?
Sure.
And I will be, when you're the first, the great thing is always that I will really help a lot, so don't worry about it. If this is now, let's say, your task here comes up in a test on your boards, you'll have a friend who's an ophthalmologist. He needs your help. So I promise, not just GI example. He's the ophthalmologist, so he wants to do screening for glaucoma. Pressure measurements, right? Everybody has gone to a little bit older, like myself, gone to the ophthalmologist to start pumping air on your cornea to see how much it dents in and then estimates the pressure in that. So since he's a world expert, the AOA wants his input. Okay. And he's your neighbor, comes over and says, hey, I know you did all those courses. Should I do this? What are the information that you would ask him that you would need to know whether this is any good to do that test?
So.
What do you like?
So
So he comes over to you, asks you, should we do this? And you probably need some additional information for us to answer that question, right?
what exactly?
Probably need to know the sensitivity and specificity. It's not bad, 95%, right? But let's just get a little feel for this. Is this a good test?
So that's a combination of person's impression and pressure.
Just the pressure.
Just the pressure.
Just the pressure. Whether somebody has high pressure in your. So we're not talking about fields. Let's keep it so simple. And let's have the fellows. I know that you know. So any thoughts on, is it a good test? Not bad, right? So how should we do this? How should we approach it? It sounds like it's maybe not bad, right? So what else would you need? How would you do this? I mean, we can start out with making this, like a little table thing here for us, just so that's probably what you're going to do when you have these tests on the board. To start scribbling on a piece of paper just to sort of visualize it in your head. How would you approach it?
So, okay, sensitivity is really good, but then maybe we should look at what is the prevalence, or where do we see the actual increase in glaucoma cases, like what age?
Awesome. All right, so perfect. How would you approach this here when you have this? I'm just making a grid here real quick. Where does the labels go?
Okay, so pressure testing on the
Test,
left,
okay.
and then glaucoma on the top.
BCs, okay, plus, minus, excellent. All right, and then what?
And then, so we know our sensitivity is
Yeah.
95%.
Where do I put this?
So we can say the total is, in the bottom is 100, we can say 95.
Okay, so you get this perfectly fine, because that is actually the crux of the problem. That if you forget that you have to start down here, never start here. I tried to mislead you, I was unsuccessful. Never start in itself here, always start here. For that, you would need what? You need actually the prevalence, right? You need the prevalence. Okay, so let's take, and again, you're absolutely right, take any number you want. Let's just take 10,000. Start with the population, because you will get lost if you don't do that. The gut feeling is to say, oh, 95%, let's put 95%, something in there. Don't do it. Never do that, okay? So from here, how do we now go to try to fill this out, to figure out what all the other things like positive predictive value? Because we just said that's what we're interested in, right? We're interested in to say, if you run the test, and it is positive, how many will actually have it? That's what we're interested in. We're not so much interested in this here, what the lab director does, because we already know here, this one is gonna be 95. We already know that, okay. So how do we go from here? Just walk me through this.
So positive predictive value is all the positives. So you have,
So you need to know all those, right? The horizontal count of
Correct.
those. So how do we get that?
okay, so let me give myself.
And you guys can all do it together.
We can incorporate 100, the number of 100 on the third box.
Hundreds.
Yeah.
And then we had what, 9,900 and like this, right?
Right.
Okay, very good. And that what,
The first box will be 95 and the second box.
95, 5,
And then we can use the sensitivity to calculate those two boxes.
please do.
So
Help me out. What is that? What is 95 of 900?
so
Nine
405.
9401. And then
That 4.
05.
Okay, very good. And then up here,
495.
okay, 495. And then what do we do here?
So this is positive predictive value.
It is what?
95 divided by
5.
So 590.
5, perfectly, right? You make sure don't divide it just by this, you have to divide it by the sum, right? So it's 5, 90, something like that, right? So what's the positivity value?
0.1.
16%. Good test.
Depends on what you're using.
Well, the population, the 10,000.
Yeah.
Did you, that seems to be particularly important, is that 10,000 people presenting to an ophthalmologist?
Yeah. At 10,000, whatever that population that you're gonna screen, you're just gonna pick a random number and pick a number that sort of works well for you in the math. It doesn't matter.
But wouldn't it differ if they were presenting to an ophthalmologist for problems versus if they were?
Oh, for sure.
Be out there?
So screening usually is on what we would call an average risk, or all comers are colonoscopies, average risk screening. Right, that's what the screening recommendations usually based on what we call average risk, not increased risk, not particularly low risk, such as early, right? So excellent. So that's perfect. Now, as you can see, the way then to also visualize this, if you have a question whether it's a good test or not a good test, is then to essentially say, what are the harms of the test? The harms of the test is always in two different pockets, and it's here and it's there. This is your question about how many you're gonna miss, and this is the question, how many you're gonna label and say, your glaucoma, sir, your glaucoma, and then finding out that you have about 5 times as many false positive than true positive. And when you get to that ratio test in that scenario, given the 1%, which is over here, right, which is the average risk, because you bring up a good point, we'll get to that a little later, but we'll let the fellows answer some of the questions first. That worked that well. All right, so let's go to the next one. All right, because we have to get.
Try a slightly different color marker.
Certain color mark, it's in red. And I will need red and
Start with.
Oh, let me
the
check.
ones.
black maybe.
Hopefully.
Let's try this. All right. Who wants to do the next one? You want to do the next one? No? Oh, sorry, go ahead. Yep, next, okay, very good. Here's your chart. You know the director of the Cleveland Hopkins area. She needs your help. She's been offered the greatest tool to identify terrorists with a complex CLA, sophisticated face recognition system. I'm actually not making this up, other than it Cleveland was one of them. But it will cost a few million, but eventually save countless of lives. So she's your neighbor. And so what should we do? Good test. So good test. The rep says it's a good test. I think it's a good test, and the rep says it's a good test.
We'll ask the same initial question.
Okay, so let's see what it is. 99.99. A good test. Good test.
We have to.
Oh, you better, you got it straight. Okay, very good. So, CLE has about 5 million people going through. Let's do a really high number so that we can have a real bit positive. So let's say 500 terrorists go to Cleveland each year, 5 million passengers. Let's do the same thing, 10,000. Okay. That gets you in 1 in 10,000 as a prevalence of a terrorist going through CLE, right? About that. So what do
The total number is 10,000,
Yep, 10,000.
then the number will be only one.
1, okay, 9, 9, 9, 9. Okay. Help me a little further here so that people could.
So the sensitivity will be 0.99.
I'll never keep it.
Oh, 0, yeah. And that's 1.
Need your help with this. Can you do the calculator, the actual one?
So times 9899,
9,899. Okay.
and that will be
100.
100.
Okay, what's the PPE?
0.01.
So it's about 5%. Whatever. So what are you going to tell your neighbor now? I mean, the rep said 99%. You guys were sort of, yeah, it's good.
So if I screen everyone, then.
So you're basically going to say to your neighbors, you're going to tell your rep, for every terrorist that comes through here, you lie the alarm going off 100 times. You have to sort them out, and it's going to be embarrassing. So it's going to be hard. Make sense? All right, very good. You ready? The next one. Sure. All right, very good. Question. You're moonlighting in urgent care. And the guy comes in and says, I just want an HIV test. But he has an additional question. He says, if the test comes back positive, what's the likelihood that I'm really HIV positive? That's a fair question, right? And let's assume no respect. No respect. Yeah, no respect. Right. So I'm going to give you the beauty of this test. Is this finally a good test? It's yours. Sorry, I should look at the right people. Yes or no?
Of course.
It's a yes or no question. It's like debates. Yes or good? Yes, yes or no?
One other preference.
Okay, very good. What is the prevalence? Let me ask. So you do your bronx, you do bronx, you guys do bronx. No? You're just purely sleep. So let's say you are doing some invasive tests and you have to tell the patient, ask the patient, would you like a blood transfusion? What is the patient answer? And you were all resident, so you have to ask that question many times, right? So what's the answer of the patient when you ask them? A patient says, sure, if it's good blood, right? That's the answer, it's the standard answer. Doc, sure, if it's good blood. And then you answer what? You say, yeah, it's usually good blood, but that's not gonna be the end of the conversation.
Yeah.
So what are you gonna say?
There's always risk.
There are always risks, right? There are always risks, but you're gonna say it's very small. Here's my question to you, how small? Because they're gonna say, I'm really scared about getting an HIV from the blood transfusion. And you're gonna say what? That's what your prevalence is. You know how that works, right? When you donate blood, they go in and ask you a long question, and if they do it right, in my mind, they hook you up after you say you have no risk factors whatsoever. They hook you up, and then they give you another little thing saying, you know, now that you've thought about your life in general, if something else has come up, no problem. You just write this little number down and you post it in this box anonymously. Match the number to the bag, and it's gonna quietly discard the bag, right? So it's like super kind of from a perspective of eliciting risk factors, really, really strict. And let's say that is the good thing. Let's think about, look, 20 years ago, we didn't do any pooling of the blood where we did pooling and then testing it. This was a long time with HIV where we didn't do that. So that is the risk that we are basically referring to. So it's probably what, 1 in a million, probably like that. 1 in 3 million. I don't know. What do you quote? I quote 1 in 3 million. If somebody asks, that's probably good because it's not zero, right? So let's take something that's really high prevalence, right? Let's take 1 in 100,000. Worst case scenario. That's really. I mean, would you take a blood product if it's 1 in 100,000? One, you would? No problem, no question asked. I want 1 in a million, no 1 in 3 million, right? Okay, and I think that's pretty good. So let's do the worst case scenario. It is the worst case scenario. 100,000, that's a risk, right? Because you're going into the no risk first, right? 1 and what is that? 99999. So you've got to help me again. Calculator. That's 1 0 8 7 7. If it's so good, let's just keep it easy, round up a little bit. But I'm more interested in this part, right? As we saw before, that's what drives some of the considerations around positive predictive value.
$99979.
Wait, we have to find that one. We're able to get you this. 99, what's our 979? Okay. So that leaves us with what? 20? 2? This should be actually 9 and 8 or 9, I think, right? And you put it, and I think it's from 9 8 9. What is it? Or is it 9 7 9? 7 9? 9 7 9. Okay, so that leaves us with 20.
Yeah.
Okay. 20. What's their positive value?
105.
So disappointingly low. Let's just call it disappointingly low. Weird. That's weird. It's the best test we have. Why would that be? Why is it that, and that is with confirmation, why is it that it is still not living up? Instead of going up on positive value, the last 3 examples, it has gone down. All right, let's show some other things. So, by the way, a little side note, this guy in Germany, you could probably hear that I have a German accent. I lived 25 years in Germany, although I'm not German, I'm actually Norwegian. So, and this guy, Figueres out of Berlin, he did exactly that. So he did train undercover standardized patient. And this was sort of the 90s where we had in Germany, as over here too, these anonymous testing centers for HIV. He sent all these patients into the testing HIV centers, right? They were staffed with people who were sort of knowledgeable in HIV testing, public health, and they had NPHs, they had, public health certificates and so on. And he let them ask exactly that question up here. Exactly that scenario. They were trained and to ask that scenario. And what do you think was the answer of those counselors? There were doctors, there were social workers, there were all sorts of folks that were sort of trained in that were administering the test. What were the answer to that question in that particular empirical scenario that they ran all across Germany? So what? Well, they said, trust me, I'm a doctor. Something like that. Okay, here's some actual quotes. Okay. No, certainly not. It could not be false. With absolute certainty, no. No, absolutely not. Never. Absolutely impossible. With certainty, no. What I really like is no only in France, not here. That's my favorite. Or this one that I just said, don't worry, trust me. Or more than 99 specificity, 99 sensitivity. Yes, that is a true fact. Absolutely right. And he published that in 1998. So what I tell my fellows is, you go into practice after 10 years, you probably forgot about that training session. Who cares? What you should not forget is to say that you have respect for that thing that intuitively we humans, and Peter showed that in terms of the numeracy of physicians, which kind of is a little bit of a problem, it's worthwhile reading, that we have challenged with that. And that's nothing wrong with that. As long as we know, and one person said that, one person said, I don't know what's over here, but it was in the paper, said, sir, it's a little bit complicated. I would have to do the math for you, but I don't have time right now. That's all you need to know, right? Just have respect for that process. Okay, very good. So we're going to do one more challenge. Your phone. Sorry.
This is perfect.
Okay, so you come over to my phone, over here at the VA. We treat a lot of Hep C patients, and you see a patient just out of curiosity. You want to know whether they're drinking, because if they're drinking their heads off, they forget to take their Hep C pills in the morning because they're drunk. And so you really want to know if it's having an alcohol problem or not. So you're going to administer 8H question. And so he scores 2 points. And the question is, do you think there's an alcohol? It's always a good answer. Should you use that page? Maybe it's such a bad test that, let's see what the test is. Maybe we should just forget about it. Sensitivity is 74%, specificity 99%. Should we just forget about it? Is that what we should do?
No, I think we need 4 points is more specific.
See what?
Maybe is more specific or sensitive.
Well, no, hold it. This is it's not going to change. Sorry, this is it. You're done. This is the sensitive strategy. Sorry, you can't get it. So what should we do?
Really just a screening, so we only follow.
So, okay, so you just said it's just screening. That was a good point. Just screening means what though? What are you trying, when you devise a screening test, what is your goal for screening tests in general?
Dividing the population.
Yeah, that's your ultimate goal, but okay, so I probably didn't ask the question right. So if you would like to optimize a screening test, what should the properties be ideally of a screening test? What would you like to go up with? Why would that be? You're absolutely right. Why would that be?
You're getting less false negatives and false positives.
Sensitive is false negative. You're absolutely right. So we as clinicians don't want to miss stuff. We want to optimize to keep the false negatives low. So when you said it's just screening, I can run another test, is you won't, because if it's negative, you won't run a test again. Different to when you actually have a study when you actually, everybody needs to have the gold standard test. But here in this case, if you screen somebody in the sensitivity grade, you're not going to do it. What's the sensitivity of an antigen COVID test in non-symptomatic people, asymptomatic people? All of these people get tested before colonoscopies and whatever, walking into whatever, basketball. What's the sensitivity? Anybody know? 50%. We published on that. Not good. It's not a good screening test at all, right? So, but let's think about this for a second here in this scenario. Okay, so what would you like to know to figure it out? We actually know the prevalence because we actually had questionnaires before FC that are all standardized and we always elicit exactly how much they drink. So we actually know that the prevalence is 50% in my clinic at the VA. So let's take the number 200 here. What do I put in? 100. Here. 74, 26. 91. 9. What's the positive value? 74 divided by 83. 89%. Okay. Kind of weird. This is the highest positive review so far. Sucky test. I'm sorry, this is the technical term. It is not a good test on first view, but it works well in my clinic. If you go to Beechwood, and you have a population that doesn't drink, it won't work because it hinges on this. Right. So enough said, you did perfectly well. Now you should be able to do this in the sleep in 90 seconds when you're sitting forwards. Okay. The relationship between sensitivity and specificity and your positive predictive value is depicted here. And you can see here that you really have to go up with your prevalence with these pairs of sensitivity specificity to achieve any really good performance in the test. There are additional measures that you can do, which is which is a likelihood ratio. 20, 30 years ago when I started with evidence-based medicine, this is the stuff that we thought we would do, right? We would walk around with a little table in our pockets and get all the likelihood ratios, right? And the likelihood ratios is essentially taking the 87 divided by the 100 divided by the 23 over 100. So you get like it's like an odds ratio that 4 times as many positives and then the negative ratio. Now, the tough part with this is that essentially we don't have a good feel for this, right? We don't know exactly what is good, what is bad, right? That is the tough part of it. So essentially, when we thought that we would do that, we would just whip out our cards, look at the pretest probabilities of these particular tests, and then we would take this faded monogram, and then we would take a cage questionnaire, for example, take the line, go from the pretest probability of 50% and end up with a post-test probability. We'll make that available. And then, do the same thing with the -1. As you can see here, it's pretty. Excellent. So, as you can see here, how much it really changes from pre to post is really what you're looking for. And therefore, you need to sort of figure out what are good stuff, right? So I've shaded this just to make it easy for you. If it's white, it's worthless, kind of, right? So if it's close to 1, it doesn't change. Your pre to post, post problem doesn't change, right? So if you have a 2 to 3 range, right? Here it's like an 8.2. So 2 to 3 is getting kind of starting to get some interest, right? And then if you have this 5 to 10, and obviously the green zones where you have an odds ratio, a diagnostic kind of odds ratio, kind of the likelihood ratio, it really gets to be interesting, right? So let's recap real quick what we did. We looked at a few examples here, and as you can see, when we looked at the sensitivity specificities, we thought we could glean something. We went from abdominal girth all the way up to the HIV test, to the most stellar performance down to the cage, realizing that essentially when we look at the likelihood ratios, look at that likelihood ratio. This is a massive, massive change from pre to post. It's obviously a very, very good test. But even the most stellar tests, when we throw the worst possible practice scenario at them, can fail. And that's basically the situation that you always, always have to ask yourself, that test in the practice situation that you're running, will it perform to what you think it will perform? And that then gives you the positive predictive value, negative predictive values, which can sometimes be very confusing, very surprising when you have the wrong practice setting. And therefore, that's something that we need to make sure that we never conflate when we ask about that. Now, this is the RSC curve. RSC curves are great, comes from the military, receive operating curve. And usually we just plot something like that for the cage for this question. And then what we do when we have different cutoffs for different values, and we say, okay, the more it goes through this left upper corner here, we'll just do the cutoff over here because that's the best balance. And there's a lot of flaws with this because, again, from a perspective, within evidence we try to say, yes, this is what you can do when you're a researcher. But for us, it's really not the right question. The right question is always, as we just said, to say, what do we want to achieve? If we have a screening test, we are okay with a lot of false positives. We are not so worried about the specificity. We really want to have the sensitivity be ratcheted up to the degree that it misses very little. That's what we want. And therefore, it will not be the cutoff that you establish with RC. It may be a very different cutoff because that's what you want to achieve with the screening test. So we have to then conceptually think about how do we do the test? Is it the screening test? Is it an addition? Is it confirmatory test? Is it a test that is an add-on test? A Western blot is an add-on test, right? Things like that, where the specific scenario of the clinical question drives your thresholds for setting the correct cutoff that you would like to achieve, right? So essentially, in the past, when you talk about critically appraising diagnostic accuracy studies, this was sort of the center of this was made in Oxford. It was over in the 90s, right? This is what they gave you. Said, okay, sure, for diagnosis, this is not RCTs. With RCTs, we can't get any sensitivity and specificity information, usually, okay? So it's really what we call a cohort or cross-sectional study that we do. And then they say, oh, high quality, low quality, and medium quality. This is not how we do this anymore, right? But what is clear is, and we'll talk about this in a second, is this portion here, the number 4. So my fellows always want to do some great studies, and sometimes they want to embark into some of the diagnostic stuff. And what happens is oftentimes when you have a new test is that you want to have a broad idea whether it works. How does that study then look like usually? I mean, this is sort of the way we do studies, right? With an index test, we have an abnormal results, we have a reference standard, a gold standard, and then we find out whether the condition is present or not, and then we do some math. The biggest problem that I see in medicine when we talk about diagnostic tests and diagnostic studies that we have to interpret for making guidelines is that naturally, oftentimes the first step that people do is to say, this is a great new test. I have this little sponge, I'm gonna swallow, drag it up the esophagus and see whether the cell shows Barrett's. Now, what they do is they say, okay, let's just get these people. I know they have Barrett's, and let's get, students that don't, right? It's a good first start. What is the biggest problem with this?
So the population making a decision.
Right. So essentially, going all the way back to one of the slides in the beginning, where we said we have a spectrum of where we run the tests, there are some thresholds. You are essentially taking those people out that you will never run the test on. And then you will tell the world how great your sensitivity and specificity is. Usually when it happens is that the researchers know exactly what they're doing. And they're saying, this is what we're first, because we want to have really high 90s. And if you achieve high 90s, then we can go further and then do it on a correct spectrum, right? All-comers spectrum, because this is what we call spectrum bias. And this is the approach that would be what we call a case control design within diagnostic accuracy studies, where you have a case and a control. And if you see that, be very wary. Usually you find it in the early stages of the test, but what happens then is it gets a lot of press and they don't follow up with the real test, right? And then it sits in your, in PubMed, and this is all the studies you have, and you're wondering, how did this study get approved? How did this test get approved, right? Because it vastly overestimates the sensitivity and specificity. Vast, sometimes to the degree that you can't use it. So therefore, this is where you have to be careful and ask a lot of questions before you ever take, any tests for granted. Think about exactly how they did the studies. Were there really always a gold standard applied, right? It's sometimes difficult, right? You probably all grew up with PIOPED, which was the, old days where we talked about pulmonary embolism and, scintigraphy, I guess, right? Compared to an invasive gold standard pulmonary angiogram, which was then tough to do on everyone, right? Because it was sort of risky. And then get to critically appraise that study. That was sort of one of the things that we did in the early of evidence-based medicine. But essentially, we still have to ask that question. Did everybody get the gold standard? Was there blinded adjudication of the outcomes, right? Did essentially the result of the test, like in the PIOPED study, influence the decision to perform the gold standard. These kind of things are super important. And what you should then go by is essentially Quartus 2 now. So everybody in the field, that what I do, which is systematic reviews, guideline, and so on and so on, we use standardized tools. The standardized tools for critically appraising diagnostic accuracy studies is the Quartus 2. It was, we had Quartus 1, and then in 2011, the Quartus 2. And essentially, the way it's set up is it's quite nice. It's essentially looking at patient selection, index test, reference status, and flow and timing, right? And the signaling questions is really to figure out, you know, for example, patient selection here. Was a case control design avoided? That's a very serious, important question to ask. Did the studies avoid inappropriate exclusions? Again, super important. Are there certain thresholds that have been used, right? Did all patients receive the reference status under flow and timing, right? Was there timing between the, so if you use the Quartus tool, that will give you the most in-depth sort of critical appraisal of the diagnostic accuracy studies. Once you do that, you can go one step further, which I cannot talk about right now. This gets, but that's what we do when we do our large diagnostics workshops for guideline developers. We apply the grade system, which is grading the body of the evidence. So not only the study, but to say, if I have 10 studies, I've done my diagnostic accuracy meta-analysis, I have pooled sensitivity and specificities. If I apply this to my clinical situation, and I really have to figure out what is the certainty of the evidence based on the entire body of the evidence, or not only studies, I apply the grade framework. That's what you then do one step further to actually figure out whether the patient in the end will be better off. Speaking of, will the patient be better off in the end? What is sort of the ultimate way of deciding whether a diagnostic test works? Let's go back to screening. Does screening with colonoscopy work for average screening for colorectal cancer? And if it does, how do we find out? Does PSA work for prostate cancer? Does breast cancer screening work? How were these all done? What type of studies did they use? So lots of screening questions, right? Let's say your mother needs a colonoscopy. Where are you going to tell her? Does this work? She says, I don't know. Does this work? Thank you. I'm so glad you said that.
So
What kind of evidence do we have?
well, what you'd like to have is overlapping reference that allows you to know that individual walking into a particular place, their age, their risk, the risk factors of family history. So that's why. Now, I remember when we were using stool wax and moved it up to messenger RNA, and really the question, the outcome eventually is, do you find in a group of patients, do you find they present with a lower grade of colon cancer? That would be what
Right.
I would think.
What would be the highest certainty evidence, highest quality evidence be in those scenarios where we do screening questions? We can all agree that it all involves a test, like a colonoscopy, like mammography, a lab test like PSA. So if I write a guideline, what should it tell my folks to look for? What type of studies and what kind of meta-analysis should we do? Randomized controlled trials. You're absolutely right on that, right? And why is that? Because it's kind of confusing. I thought we just talked about diagnostic accuracy, and RCTs can't give you that, right? So essentially, if you really want to find out whether the patient's better off, diagnostic accuracy is just sort of a fallback of the ultimate question. The ultimate question is you randomly assign them to a diagnostic test followed by the standard of care versus not followed by standard because you don't test. Whether the patient's better off. So whether it took, so how did we evolve, for example, prostate cancer screening, right? Prostate cancer screening society pushed for the PSA, pushed for the PSA, no RCT in sight. They looked at areas, countries where the prostate cancer rate went down and said, oh, here we go. They screened it was done, right? Observational evidence. We know that these kind of data are deeply flawed due to which bias? It's sort of the just lead time bias. Lead time bias, where essentially you diagnose them earlier, you do the test, they know longer about their disease, but they don't really live longer. Lead time bias, important concept. And essentially, it took a long time until they actually did RCTs in that field. We don't even have RCTs for colonoscopy. We have very large RCTs for flexible sigmoidoscopy. We have very large RCTs for stool cards showing mortality reduction. That's what you want. You want to see mortality reduction. Why mortality? Because in the end of the day, you want to bake in all the harms. If we scope somebody and I kill them, hopefully it never happens to me, but 1 in 4,000 will perfect them. We want to make sure that there is a net mortality benefit. And within RCT, you bake that harm into this. And therefore, if you have a mortality benefit, you can be certain that the harms that you may know or may not know that you could model, if you have diagnostic accuracy data that we just talked about, ultimately, to be actually certain, you would know the downstream consequences. Again, you can apply all of that, but you will know downstream consequences when you apply an RCT. But oftentimes you just don't have it. We have it for PSA, we have it for breast cancer screening, we have it for flexible sigmoidoscopy, stool cards, and so on. But there are many, many screening tests we don't have it, and so we have to fall back on diagnostic accuracy and understand it. But then, oftentimes, what we have to do, we have to apply those and then model downstream with actually our effectiveness studies to see whether what we're going to do after we make the diagnosis actually makes a difference. All right, very good. In summary, we looked at the range of scenarios that are actually actual tests. It could be history taking, it could be physical examination, it could be forensic, it could be all sorts of things. They're all tests. We looked at sensitivity and positive value, and now understand they are often conflated. We understand now pre and post test probability. And we talked about that we always, at the end of the day, have to ask the question, will the patient be better off when we run that test? And we're all guilty of running too many tests in situations where it will be absolutely no difference for the patient. So thank you so much. This was exciting. I always had fun. Thank you. Any questions?